Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we will be discussing about various thyroid disorders. First of all, we will be discussing about the anatomy of the thyroid gland, and we will be discussing about few diseases related to the thyroid gland, especially hypothyroidism. Hypo means deficiency of thyroid hormone. So let's start with the thyroid gland, an introduction. Thyroid gland produces two hormones. One is thyroxine, T4, and the second one is triiodothyronine, that is T3. So two hormones are produced, T3 and T4. The important functions of the thyroid gland includes cell differentiation during development. It helps in maintaining the thermogenic or metabolic homeostasis in the adult. The thyroid is derived from the Greek word thyros, which means shield, plus eidos means to form. So thyroid is like a shield that is formed in the body. It consists of two lobes that are connected by the isthmus. Thyroid is located in the anterior to the trachea between the cricoid cartilage and the suprasternal notch. The normal thyroid gland is around 12 to 20 grams in size, and it is highly vascular and soft in consistency. The recurrent laryngeal nerve traverses through the lateral border of the thyroid gland. The thyroid gland develops from the floor of the primitive pharynx during the third week of gestation. The developing gland migrates along the thyroglossal cyst to reach its final location in the neck. There are various autoimmune disorders of the thyroid gland that can stimulate overproduction of the thyroid hormones, like that is known as thyrotoxicosis, or there may be glandular destruction of the hormone, that is known as deficiency, and it is known as hypothyroidism. So there can be thyrotoxicosis or there can be hypothyroidism. The benign nodules and various forms of thyroid cancer are relatively common. So let's start with hypothyroidism first, when there is deficiency of the thyroid hormone. Hypothyroidism is a common condition of various causes, but autoimmune disease like Hashimoto thyroiditis and thyroid failure following iodine 131 or surgical treatment of thyrotoxicosis accounts for about 90% of the cases. There are three causes of hypothyroidism. We have primary cause, transient cause, and secondary cause. Transient, that is lasting for some time. Now, in the primary cause of hypothyroidism, there is autoimmune hypothyroidism, which includes Hashimoto thyroiditis, atrophic thyroiditis. There is iatrogenic cause, which includes iodine 131 treatment, subtotal or total thyroidectomy, external irradiation of the neck or lymphoma or cancer, drugs, which includes antithyroid drugs, congenital hypothyroidism, which includes absence or ectopic thyroid gland, dyshormonogenesis or TSH-resistant mutation. There may be iodine deficiency and infiltrative disorders like amyloidosis, sarcoidosis, scleroderma, and renal thyroiditis. So the causes of primary includes autoimmune hypothyroidism, iatrogenic, drugs, congenital hypothyroidism, iodine deficiency, and infiltrative disorders. The causes of transient hypothyroidism include silent thyroiditis, including postpartum thyroiditis, subacute thyroiditis, with a withdrawal of thyroxine treatment in the individuals with an intact thyroid, after iodine 131 treatment or total thyroidectomy for Graves' disease. The secondary hypothyroidism causes includes hypopituitarism, which includes tumors of the pituitary surgery or irradiation, infiltrative disorders, Sheehan syndrome, or trauma. There may be hypothalamic diseases, which includes tumors, trauma, infiltrative disorders, or idiopathic causes. Now, what are the symptoms of hypothyroidism? The symptoms of hypothyroidism includes tiredness, weakness, dry skin, cold skin, hair loss, difficulty in concentration and poor memory, and constipation, weight gain, and poor appetite. There is dyspnea with hoarseness of voice, menorrhagia, later oligomenorrhea and amenorrhea, paresthesias, and impaired hearing. Now, what are the signs of hypothyroidism? The signs of hypothyroidism includes dry, coarse skin, cool peripheral extremities, puffy face, hands and feet, which includes myxedema. There is diffuse alopecia, bradycardia, peripheral edema. There is delayed tendon reflex relaxation, carpal tunnel syndrome, and serous cavity effusions. There is another condition that is known as congenital hypothyroidism. This occurs in around 1 in 4,000 newborns. The cause of congenital hypothyroidism is due to thyroid gland dysgenesis in 80 to 85% cases. The newborn errors of thyroid hormone synthesis in 10 to 15% cases, TSH-resistant antibody-mediated in 5% individuals, and clinical manifestation, which includes majority of the infants, appear normal at birth. Prolonged jaundice, feeding problems, hypotonia, and enlarged tongue, delayed bone maturation, and umbilical hernia can also be seen. The diagnosis of congenital hypothyroidism is done by neonatal screening program based on measurement of TSH or T4 levels by heel prick blood specimen test. The treatment is by T4 institution at a dose of 10 to 15 microgram per kg per day. Another variety consists of autoimmune hypothyroidism. Autoimmune hypothyroidism is associated with goiter, that is known as Hashimoto or Goiter's thyroiditis, or a minimal residual thyroid tissue, that is known as atrophic thyroiditis. Another cause of autoimmune hypothyroidism includes subclinical hypothyroidism and clinical hypothyroidism or overt hypothyroidism. Now, what is the prevalence of autoimmune hypothyroidism? The prevalence of autoimmune hypothyroidism with the incidence rate of autoimmune hypothyroidism is up to 4 per 1,000 women and 1 per 1,000 men. It is more common in females with a ratio of 4:1. The pathogenesis is markedly lymphocytic infiltration of the thyroid gland, atrophy of the thyroid follicles with absence of colloid, and mild to moderate fibrosis. The clinical manifestation of autoimmune hypothyroidism includes, this is slow insidious onset, with the goiter may not be enlarged, but usually irregular and firm consistency. The skin is dry, decreasing sweating, thinning of the epidermis, and hyperkeratosis of stratum corneum can be seen. There is increased dermal glycosaminoglycan contact strap water, giving rise to skin thickening without pitting, that is known as myxedema. There is puffiness of the face with edematous eyelids and non-pitting pretibial edema. The face becomes pellar, often with a yellow tinge of the skin due to carotene accumulation. The nail growth is retarded and the hair is dry, brittle, and difficult to manage and falls out easily. There is thinning of the outer third of the brows. There is constipation with weight gain despite of poor appetite. The libido is decreased in both the sexes and the patient complains of menorrhagia with a reduced fertility and incidence of miscarriage is increased. The patient complains of myocardial contractility and pulse rate are reduced, leading to reduced stroke volume and bradycardia. There is increased peripheral resistance with diastolic hypertension. The blood flow is diverted from the skin, producing cool extremities. The fluid may be accumulated into the serous cavities and in the middle ear, giving rise to conductive deafness. Now, what are the investigations that can be done in case of hypothyroidism? In hypothyroidism, we have to check for the TSH and T4 levels. Demonstration of TPO, that is thyroid peroxidase antibodies, is present in greater than 90% of the cases. Fine needle aspiration biopsy to confirm the presence of autoimmune thyroiditis, and ultrasound can be done. The differential diagnosis includes an asymmetric goiter in Hashimoto thyroiditis that may be confused with a multinodular goiter or thyroid carcinoma. The other causes of hypothyroidism includes iatrogenic hypothyroidism, iodine deficiency, and secondary hypothyroidism. In iatrogenic hypothyroidism, in the first 3 to 4 months after radioiodine treatment, the transient hypothyroidism may occur due to the reversible radiation damage. Because TSH levels are suppressed by hyperthyroidism, unbound T4 levels are a better measure of thyroid function. Iodine deficiency is responsible for endemic goiter and cretinism. Secondary hypothyroidism, other anterior pituitary hormone deficiencies. TSH level may be low, normal, or even slightly increased. The diagnosis is confirmed by detecting the unbound T4 level. Now, the lab evaluation in case of hypothyroidism. The measurement of thyroid hormones like TSH assays. Test can determine the etiology of thyroid dysfunction, which includes circulating antibodies against TPO and thyroglobulin. Radioiodine uptake and thyroid scanning for the radioisotopes of iodine, like iodine 123, 125, 131, and technetium 99. And thyroid ultrasound can be done. For the management of hypothyroidism, daily replacement dose of levothyroxine, usually 1.6 microgram per kg of body weight. Special consideration in women with a history of high-risk hypothyroidism should ensure that they are euthyroid prior to the conception and during the early week of pregnancy, because maternal hypothyroidism may adversely affect the fetal neural development and causes preterm delivery. The presence of thyroid autoantibodies alone in euthyroid patient is also associated with miscarriage and preterm delivery. So this was all about hypothyroidism. In the next lecture, we will be discussing about thyrotoxicosis or hyperthyroidism. I hope the session is clear to you. If you have any problem, please write in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture with thyrotoxicosis.